I welcome everyone, and I thank the organizers for the invitation. My name is Lóránd Erdélyi, and I'm a clinical pharmacist at the hospital in Győr, and an assistant lecturer at Széchenyi University. Today I would like to briefly summarize the factors that modify the pharmacokinetics during continuous renal replacement therapy. The factors influencing the removal of drugs can be classified into two groups. The physicochemical properties of the active substance, protein binding, volume of distribution, molecular weight, and drug charge, and the settings and properties used during the CRRT procedure, modality, effluent flow rate, blood flow rate, fluid replacement, pre or post dilution, and the membrane type. Let's first look at the properties of the drugs. Protein binding plays an important role in both the pharmacological action and the removability of the drugs by CRRT. Only the free drugs has a pharmacological effect. When a drug is bounded to the protein, it undergoes a physical change, becoming inactive and increase in molecular weight. Due to this increased molecular weight, the drug cannot pass through the CRRT membrane and thus cannot be removed via extracorporeal treatment. With a lower plasma protein concentration, we would expect a higher concentration of free drugs. However, this does not occur because the free drug diffuses into the tissue, establishing a new equilibrium. As a result, the concentration of the free drug does not change significantly. The volume of distribution describes the extent to which a drug is distributed between tissues. VD is directly proportional to the amount of drug distributed in the tissue. A large VD means a larger tissue distribution. In general, drugs with high lipid solubility, lower polarity, and low protein binding have a higher volume of distribution. From the point of view of CRRT, the volume of distribution can be an interesting parameter because its effect to the amount of the active substance that does not diffuse from the bloodstream, and the free drug that remains here can be removed. In critical ill patients, the measured VD may differ from the estimated VD. A large amount of bleeding, ascites, or other changes in fluid status, even dehydration or edema, can significantly affect it. Most drugs have a molecular weight of less than 500 Daltons. The pore size of the membranes, what you use in CRRT, is also permeable to molecules of 20,000 to 30,000 Daltons. Therefore, based on the size of the free drugs fraction, it can pass through the membrane. However, the drug fraction bound to albumin cannot pass through the membrane. Since the size of albumin alone is already 68,000 Daltons. If the procedure is performed only with hemodialysis, diffusion shows significantly reduced clearance of molecular weight above 500 Daltons. Okay, the modalities should be mentioned in the CRRT procedure: hemodialysis, hemofiltration, and hemodiafiltration. Those modalities involve different process and affect pharmacokinetics to varying degrees. In hemodialysis, the process involved is diffusion. In hemofiltration, it is convection, and hemodiffiltration, it is a mixture of hemofiltration and hemodialysis. During CRRT, pre or post-dilution is used, display an important role in the concentration of drug entering the membrane. Drug concentration affects drug removal efficiency. If the case of the post-dilution, the removal of the drug from the blood will be more intensive due to the higher drug concentration. Let's examine the process taking place in different modalities. During diffusion, the driving force of the material flow is the concentration gradient. The process occurs passively, meaning that materials can flow through the membrane in both directions according to the concentration difference. For example, urea can exit into the dialysis fluid, while bicarbonate can enter the blood through the membrane. The speed of process is inversely proportional to the molecular weight and directly proportional to concentration difference. Smaller molecules pass through the membrane more easily and quickly. Above 500 Dalton diffuse slow down significant. Convection or mass transport is the flow of materials through the membrane, driven by the pressure difference between the two sides of the membrane. Material flow from the area of the higher pressure to the area of lower pressure. In this case, the flow of materials possible even against a higher concentration gradient. It is necessary to use dialysis solution. Only the resulting effluent must be drained, and all or part of the lost fluid must be replaced. The equitation describing clearance in different modalities illustrate the effects of effluent flow rate, blood flow rate, dialysis flow rate, pre or post-dilution, post-fluid replacement, and membrane characteristic on clearance. In hemodialysis, the dialysate flow rate and the saturation coefficient at the primary determining factors. In post-dilution, hemofiltration clearance is determined by the effluent flow rate and sieving coefficients. When pre-dilution is used, the drug concentration at the membrane decrease. Consequently, the equitation show the blood flow rate divided by the sum of the blood flow rate and the fluid replacement flow rate, resulting in a volume less than 1. This leads to decrease the clearance due to the lower concentration. In addition to the well studies and the strongly supported mechanism, there is a process that is significantly under-researched, the absorption. Absorption is a binding of the substance to the membrane surface, influenced by the charge on the membrane surface and the charge of the molecule, similar to protein binding. This process can reduce the amount of the free drug's fraction. The binding of the drug to the membrane surface further enhances clearance, and it's likely a saturable process. This means that after a filter change, absorption will be more significant than with a filter that has been in use for many hours or days. Binding to the membrane raises several questions. What kind of bond is formed? It is reversible or irreversible? Will there be an equilibrium? How much active ingredients remains on the membrane? Should any action be taken, such as increase the dose, giving a loading dose, or giving a higher loading dose? current data does not provide answer to this question, indicating that further investigation is warranted. The factors mentioned above influence the elimination of molecules from the body. The rate at which molecules is removed affects its serum concentration, which is crucial for the success of drug therapy. If the serum concentration is subtherapeutic or toxic, the drug will not have desired the effect. Some drugs have effectiveness that can be easily and quickly determined, such as antihypertensives. By simple measuring blood pressure, we can ascertain in the dose. The dose is appropriate for the patient. However, for many drugs, this is not simple. When therapeutic drug monitoring is available, we are in a fortunate and easy situation. By taking a blood sample at the right time, we can measure whether a drug is being used at the correct dose. Unfortunately, this option is not available in our hospital, and all medication can be measured. During antimicrobial therapy in sepsis, it is crucial that the drug level exceeds the minimum inhibitory concentration, is used at a therapeutic dose, and is not toxic. If we can't measure the level of given drug, we must rely on literature data. Thus, adjustment based on pharmacodynamic properties is a good approach in antimicrobial therapies. For antibiotics with concentration-dependent killing characteristic, a higher dose can be administered at lower frequencies. For antibiotics with time-dependent killing characteristic, the goal is the maintenance serum level above the minimal inhibitory concentration for as long as possible during the treatment. Therefore, is better to reduce the size of dose rather than frequency. Before and during any CRRT treatment, clinicians should consider factors that may affect the treatment. Decision should be supported by the literature. Let me show you a simple flow chart to help with this decision. The first step is to examine the patient's relevant parameters, the physicochemical properties of the drugs, and the CRRT settings. The next step is to check whether the drug is excreted with the kidneys and whether it can be dialyzed. If dialyzable, estimate clearance using available literature, manufacturer's recommendation, and summary of product characteristic. If not dialyzable, use the dose recommended for anuria. Finally, if possible, monitor drug level, then conduct ongoing reviews until the therapy is stopped. Finally, allow me to connect this modern procedure with the famous phrase of an ancient scientist, as Paracelsus said, dosis sola facit venenum. I think that statement has been valid ever since, only in more scientific environment. Thank you for your attention.